Welcome back. This session, we're going to talk a little bit about patient advocacy, clinician education, and access to care. I'm glad to be joined by Lorraine Johnson, Dr. Elizabeth Maloney, and Pat Smith. Why don't I have them introduce themselves? Why don't we start with Lorraine?
My name is Lorraine Johnson. I'm the CEO of LymeDisease.org, and I'm the principal investigator of MyLymeData, our patient registry project, which has enrolled over 17,000 patients.
And Dr. Maloney?
Hi, I'm Dr. Betty Maloney. I am president of Partnership for Tick-Borne Diseases Education. We are a nonprofit providing online accredited CME modules for clinicians that it's free for everyone.
And Pat Smith.
Hi, I'm Pat Smith. I'm president of Lyme Disease Association, Inc., a national nonprofit, and I have been a Lyme educator for 38 years.
Great. And why don't we go into a few sessions, a few presentations, and then we'll have a little time for discussion. So why don't we start with Lorraine?
Hello, everyone. I'm Lorraine Johnson, the CEO of LymeDisease.org and the principal investigator of MyLymeData. LymeDisease.org is one of the oldest advocacy organizations in the nation, over 30 years old. We are also one of the largest and most trusted communications networks, providing news to the community. Our mission is to harness the power of tens of thousands of patients to improve patient care and accelerate the pace of Lyme disease research. We do this through communications, the MyLymeData patient registry, and science-based advocacy. Today, I'm going to talk to you about what we have learned from registry data about antibiotic treatment for chronic Lyme disease. And let me start by telling you a little bit about the registry. MyLymeData is a patient-led research project that allows patients to pool their data to accelerate research using real-world evidence. The registry uses the same technology that the NIH uses for its registries. We launched the registry in 2015 and have enrolled over 17,000 patients. Along the way, we formed collaborations with academic researchers, biostatisticians, and the Lyme Disease Biobank, a Bay Area Lyme Foundation program. We have also worked with 2 industry partners to recruit for diagnostic clinical studies, and our data was included in a National Science Foundation award. We have published 6 peer-reviewed studies that have been cited by over 75 other peer-reviewed publications, and our data has been used extensively to support state and federal legislative actions and inform advisory committees, including the Tick-Borne Disease Working Group, where it has now been cited over 90 times. The MyLymeData is so important because it usually cannot be obtained from any other source. Today, I'm going to talk about a couple of our studies that have focused on antibiotic treatment. But before I turn to the studies using the MyLymeData registry, I want to point out that we launched the registry because the National Institute of Health has funded only 3 grants to assess treatment response in Lyme patients who remain ill after a short course of antibiotics. And the last was funded over 25 years ago. The NIH trials were very small. Sample size ranged from 37 to 129 subjects, and they excluded between 89 to 99% of patients who sought to enroll. And these NIH retreatment trials and the way they were interpreted did not provide patients and clinicians with the answers they need to make treatment decisions. Randomized trials are great, but as Rob Califf, who currently heads the FDA, says, they take too long, cost too much, and don't apply to most people. So we thought, what if we flip that around and enroll very large samples and look at treatments patients are actually using to see what works? MyLymeData was launched to provide the large inclusive sample populations and to gather real-world data necessary to inform treatment decisions. None of the NIH trials consider different types of treatment or treatment beyond 90 days. MyLymeData considers all treatments and all treatment durations. Because MyLymeData looks at the myriad of treatments that patients actually use, It's like running 1,000 studies at one time. This is how it accelerates the pace of research. When we looked at other diseases, for example, hepatitis, we saw that they looked at how patients responded to treatment and grouped them by treatment response. Then they looked for differences between treatment responders, high responders, and non-responders to see what was different. And it makes sense, doesn't it? You want to identify patients who become well or who are high responders and see what they did so that you can let other patients know. Does it matter if they take antibiotics or not? Does duration of treatment matter? Does the expertise of clinicians who treat them matter? That's what we wanted to find out. But to answer these questions, you need really large inclusive samples in the thousands. And the two MyLyme data studies I'm going to present involved really large samples, including over 3,500 patients who had chronic Lyme disease. And MyLyme data includes the type of patients typically seen by clinicians. To be included in this study, you needed to be a US resident who was clinically diagnosed with Lyme disease and who was treated with antibiotics but remained ill 6 or more months after treatment. Because our sample is so large and inclusive, we were able to do something that the NIH trials could not do. We were able to look at different subgroups of patients. For example, patients who had chronic Lyme disease and now are well, or who have improved substantially, and then see what they did that was different from the people who did not respond to treatment. The first thing we had to do was identify patient subgroups for treatment response. Other researchers have done this before, and we were able to use their widely used and validated survey questions. So we asked patients to tell us whether they were better, worse, or unchanged since taking antibiotics. And this type of question is routinely used by doctors when they see patients. It's also used extensively in research and is called the Global Rating of Change Scale. The CROP NIH retreatment trial included a version of this question, for example. If the patient says they are better or worse, we then ask how much better or how much worse. And based on their response, we place them into subgroups. Patients who are unchanged or worse since treatment were considered non-responders. Anyone who improved was considered a treatment responders, but we were only interested in people who improved substantially. These patients were considered high responders. Now, not a lot of patients who are well are motivated to join the registry, but some do, and we looked at them too. To put it simply, we looked at 3 groups of patients: well patients, high responders, and non-responders. Next, we divided our sample into these 3 groups. And here's what we found. 52% said that they had improved to some degree on antibiotics. 35% said that they were moderately to a very great deal better, and these were our high responders. All other patients were considered treatment non-responders. Most of the non-responders, approximately 37%, reported that their condition was unchanged. Only 12% reported that their condition was worse. Note that our question asks about improvement at the time the survey is taken, so non-responders and low responders may continue to improve over time. We wanted to know, how are these groups different? But first, we needed to make sure that these patients had improved on other specific measurements of improvement. We were essentially validating our sample. So we asked these patients how much their overall condition had improved from the time they were at their sickest. Were they 25%, 50%, 75%, or more better? And as you can see, 61% of high responders and 94% of patients who were well said they had improved 75% or more. They also reported that they had a substantially higher quality of life and a greater reduction in fatigue severity. So patients who were high responders or well reported improvement on the types of other measures that you would expect. Chronic Lyme patients use lots of different treatment approaches. Some use antibiotics alone, some use no treatment, some use alternative treatments only, and some use a combination. We wanted to know what types of treatment patients who are high responders and well patients were using. And here's what we found. This chart shows the percentage of patients who reported using antibiotics either alone or combined with alternative treatments, and whether they are patients who are well, high responders, or non-responders. And notice that only 38% of non-responders report taking antibiotics. In contrast, 59% of high responders and 76% of patients who are well report taking antibiotics. This suggests that being on antibiotics matters in terms of having a better treatment response. The next question we looked at was whether treatment duration matters. Are patients who are well or high responders treated longer, shorter, or the same duration as patients who are non-responders? As this chart shows, most non-responders report being treated for less than a month. In contrast, 63% of high responders and 90% of well patients, and you have to do a little math here, report being treated for 4 months or more. And most were treated for more than a year, 37% of high responders and 71% of well patients. All of this suggests that longer treatment durations are more effective. And a number of other clinical studies, these are by doctors Donta, Stricker, and Cameron, have shown that patients improve with longer treatment durations. Remember that the NIH retreatment trials did not extend beyond 90 days of treatment. So these real-world results here are important because they suggest that 90 days may be far too short a treatment duration to meaningfully improve patient outcomes, at least for oral antibiotics, which most patients in my Lyme data are on. And also, remember when I said that non-responders might become responders with more treatment? Those 33% on the left, represented by the gray bar, had only been treated for less than a month at the time they took the survey. If they continue on treatment, they may improve. Next, we wondered whether the experience of the treating clinician played a role in how much patients improved. And we found that patients who are well or high responders more often are being treated by LLMDs. But this is not surprising when you consider the amount of experience LLMDs have. In our recent clinician survey, 56% of clinicians who treat chronic Lyme disease said that they had treated more than 500 patients. It is well known in medicine generally that the more experienced clinicians perform better. For example, if you need surgery, you want to find a surgeon who routinely conducts that type of surgery. Now I'm going to circle back to the NIH trials. We're often told that the NIH treatment trials do not support the use of antibiotics for persistent Lyme disease. But as Dr. Brian Fallon often points out, that is not a correct interpretation of those studies. The findings of 2 of the NIH trials, the Krupp trial and the Fallon trial, found improvement when evaluating fatigue severity. We did too. In fact, these studies showed a significant percent of people improved on this measure, roughly 65%. Our results corroborate the NIH treatment trials, and this is very important. When real-world evidence from patient registries, like my Lyme data, confirm the results of randomized controlled trials, this adds to the weight and credibility of the evidence. It tells us the prior positive treatment results were not a fluke, that they represent ground truth for the disease. Now, some of you might have noticed that 35% of my Lyme data patients are high responders compared to 65% in the NIH trials. There are a lot of reasons results may vary. We use different samples, measure different outcomes, evaluated different interventions over different periods of time. For example, the 2 NIH trials looked only at IV Rocephin, while we looked at any antibiotic, oral or IV. And most patients in my Lyme data report being on oral antibiotics. Does this factor make a difference? We just don't know, but we want to find out. And the more data we obtain, the more we can pursue this question. So let me sum this all up. Patients with persistent Lyme disease vary substantially in their treatment response. This means individualized care is important. Many patients improve substantially, 35%, and some improve enough to consider themselves well. High responders and those who are well report higher quality of life, overall improvement and a meaningful reduction in symptom severity for fatigue. What these patients have in common is that they used antibiotics to treat their illness, and they use them for long durations, typically at least 4 months and often over a year. They were also treated by clinicians experienced in treating chronic Lyme disease, LLMDs. MyLymeData conducts observational research, which means it cannot prove cause and effect. But the fact that our results use large samples and real-world evidence to corroborate key findings of 2 NIH randomized controlled trials that can prove cause and effect is very important. So if you remember one thing from this speech before I close, it would be that 2 NIH trials and MyLymeData show that for many patients with chronic Lyme disease, antibiotic retreatment works and should be the first tool in the kit for patients to get well. Bringing this to an end, the use of patient data in MyLymeData studies is critically important. It complements other research approaches and accelerates the pace of research. We have enrolled over 17,000 patients, and we encourage patients to help us reach our goal of 20,000 by visiting mylymedata.org to enroll. The more patients participate, the more we learn.
Thank you so much, Lorraine. I want to go over to Dr. Maloney for a presentation.
Hello, I'm Dr. Betty Maloney. This presentation discusses the intersection of clinician education and access to care. I have no financial conflicts. I am president of PTDE, which is a nonprofit providing accredited modules on Lyme disease at lymecme.info. Many of my comments today will be related to the paper I co-authored with Lorraine Johnson, which is Access to Care in Lyme Disease, Clinician Barriers to Providing Care. Before I get into the paper, I would like to review the Lyme landscape. We have about 500,000 new cases of Lyme disease each year in the United States. And we know from Dr. John Alcott's work that in ideally treated EM cases, so those are patients diagnosed early and treated for 3 weeks with doxycycline, that 1 year post-treatment, 44% of them remained symptomatic alone or symptomatic and functionally impaired. And we talk about the symptoms, they're at a moderate to severe level. There's an estimated 2 million patients in our country who have persistent symptoms or functional impairment following treatment. And so that's the persistent Lyme, chronic Lyme disease group that we talk about in our paper. And because acute cases continue to escalate in the country, we can expect that the prevalence of PLD, CLD will also increase. So the landscape has often been looked at from the patient perspective, and this has been through patient surveys using MyLymeData. We know that the patients with PLD, CLD have a significant disease burden and often limited access to care. We found that, or I should say Lorraine found, that about 50% of them have to drive more than 50 miles to see a Lyme treating physician, that it can take months before they get their initial consult, and that the out-of-pocket costs are high and in some cases prohibitive. But we wanted to look at the landscape from the perspective of treating clinicians. And so this is a first of its kind survey conducted through LymeDisease.org and using the SurveyMonkey online platform. There were 155 participants from 30 states. And so who are the doctors that are providing this care? Well, as a group, they have the expertise that one would need to treat patients with PLD, CLD. 81% treat a variety of conditions, so they just don't have blinders just looking for tick-borne diseases. But 57% devote more than half of their practice to the treatment of Lyme disease. They are well educated regarding tick-borne diseases. 98% have taken CME courses on tick-borne illnesses. And more importantly, they have extensive clinical experience. As you can see here, 56% have treated 500 or more patients in their career, and 38% have treated more than 1,000 patients with tick-borne illnesses. Their practices have long wait times, often 4 months or more, or some are not even accepting new patients. In many practices, out-of-state patients are common, and these responses regarding wait times and the need to travel confirm the findings from the patient surveys. Initial diagnostic delays are common in this group, and as you can see from the list, many of the items are related to physician education, or I should say perhaps the lack of physician education on tick-borne diseases. Diagnostic delays are important because they are an important cause of patients developing PLD, CLD. So there are multiple challenges to providing care to patients with PLD and CLD. Not surprisingly, clinicians report that their patients have complex situations. Most of them have multi-system disease. More than half of the treating clinicians report that their patients have cognitive impairments, and that adds another challenge to taking care of them, because everything from just taking a history to discussing post-visit plans takes more time. Memory impairments necessitate repeating information and the use of memory aids. Due to the complexity of their situation and their cognitive impairment, these patients generate many between-visit phone calls, which takes up time and energy. There are considerable challenges to providing care to patients with PLD, CLD. Most important are the structural barriers to health equity. So what is health equity? It's when every person has the opportunity to obtain their full health potential. It doesn't mean that they will, but at least they would have the chance. Structural barriers are what determine how power, funding, and services are distributed. And key barriers can include institutions, policies, and practices. So for instance, if it's the policy of an insurer to not pay for more than 30 days of antibiotics, that's a structural barrier. It's the practice of not allowing patients with PLD, CLD to have an appointment at an infectious disease practice. Professional stigma is an important structural barrier. And as described here by Nyblade, it can be considered as the exercise of power to promote conformity through negative consequences. And this is how stigma plays out in the lives of treating physicians. 75% report that they have been stigmatized. 61% note the lack of collegial support, and 11% were excluded from insurance networks, including a gentleman that I know, a very careful clinician, who was doing well with his PLD, CLD patients, but received a letter from his insurer telling him that if he did not stop what he was doing and conform with CDC and IDSA practices, that they would drop him from the insurer's network. Lyme was not a major portion of his practice, and so he had to let his Lyme patients go so that he could continue working with his other patients. Regulatory bodies are another barrier, and 39% of the respondents in the survey have had problems with regulatory boards. 19% were subject of a medical board inquiry, and those inquiries take up a lot of time, money, and mental energy. Many have been reported to a medical board either by colleagues, patients, insurers, or anonymous reporters. 11% were reported to a third-party payer insurer, much like the physician I just discussed. And a few have been subject to a hospital quality improvement inquiries. And so we can think of professional stigma and regulatory investigations as forming a wall that not only separates patients from providers, but also is significant disincentives for the clinicians to provide care. And as depicted here, this leads to a significant supply and demand mismatch, which is why patients have trouble finding a treating clinician. Thankfully, we have ways to break through those walls. I think the most important and immediate solution is robust clinician education programs, because this would reduce treatment delays, so it would reduce the number of people who progress to PLD, CLD, and by educating their colleagues who serve on regulatory bodies, this will reduce stigma and it will reduce the negative regulatory effects that many clinicians face. I want to thank you for your attention, and my references are listed here.
Thank you so much, Dr. Maloney. And why don't we move over to Pat Smith for a little presentation.
Thank you very much. Hi, I want to talk a little bit about Lyme Disease Association. We're volunteer run. We've been in service for about 31 years, and 95% of our dollars go directly to programs. The LDA has awarded 123 research grants, 159 educational grants, 107 CME conference scholarships, and we've had 60 journal publications resulting to date from our LDA supported research. Now, our Lyme Aid for Kids Healthcare Awards, we've given out $420,000 for financially disadvantaged families. We have a free nationwide online doctor referral, which it's recently updated and expanded. And we're a member of the Columbia University Lyme and Tick-Borne Disease Research Center Advisory Committee. And we're also a member of GuideStar, now Candid, where we've earned the highest level for transparency. And we're a 17-year member of the Combined Federal Campaign, which is the federal workplace giving. And we're partners with the Environmental Protection Agency, trying to stamp out ticks. Now, some of our 2022 activities we're partnering with to date, with Columbia, we're working on our 22nd Lyme Disease CME conference for 2023. And we're also working with Duke University law students this year. There's a pro bono Lyme project. And the LDA provides topics and questions on tick-borne diseases, and the Duke students are researching those and writing up papers, and we're going to be publishing those. We also work with a natural repellent group applying for research for a grant for a new natural tick and mosquito control product. And we've worked this year with the Winnebago, Nebraska Public Health Nursing Department, and they hosted a Zoom webinar for public officials. And we presented the overview of ticks and tick-borne diseases in the US and Nebraska. It's now on our YouTube channel. And we also worked with the Kendall County Health Department in Illinois for a grant for community education, including in their schools. And with the Pennsylvania Lyme Resources Network, who hosted a virtual seminar in 2022, where I presented 47 years Lyme disease, past, present, and moving forward. And that's also on our YouTube. We also worked a bit with the LymeX Prize competition, providing input to their event organization, LymeMIND, of course, today. And with legislators, the LDA initiated and provided context and language for the Child Act 2021, which was introduced by Congressman Chris Smith, Children Inflicted by Lyme Disabilities Act. This will amend the Individuals with Disabilities Education Act by adding, including Lyme disease and other tick-borne diseases in the IDEA after other health impairments. Now, looking at the spread of Lyme disease, 47 years into the disease, we still do not have accurate Lyme case numbers, but we've made progress. The CDC has presented estimates of U.S. individuals who've been diagnosed and treated for Lyme annually from 2010 to 2018. And there are 476,000 individuals now annually. That's a 59% increase over the 2005 and to 10 numbers. Now, this increase may be due to the spread of ticks into new areas, especially in what CDC Lyme surveillance definition has called low incidence states, which have little focus on Lyme in education and awareness, and doctors there are reluctant to diagnose and treat. Also, the increased research documenting established tick populations and/or actual tick infection rates with Lyme spirochetes may have contributed to higher Lyme awareness, increasing individuals being diagnosed and treated. Now, I think most of you have heard of the misuse of the CDC surveillance case definition for Lyme. And on their website, CDC has always said that all surveillance case definitions should not be used for clinical diagnosis, determining standard of care for a patient, setting guidelines for quality assurance, or providing reimbursement. But for decades in Lyme healthcare, some doctors have required patients to meet that surveillance definition for diagnosis, using it to determine the standard of care, and insurers have used it to deny reimbursement. So this prevented patients from getting care. Now, in 2022, CDC's adopted a new surveillance case definition for Lyme, which has the following statement incorporated into it. This CSTE case definition is intended solely for public health surveillance purposes and does not recommend diagnostic criteria for clinical partners to utilize in diagnosing patients with potential Lyme disease. So patients can now provide this information to their doctor if the doctor's requiring them to meet the CDC surveillance definition, or to their insurer. Now, the new definition has more tests that can be used, and included in the section called confirmatory laboratory evidence are nucleic acid amplification test and immunohistochemical assay. And plus, we have the old definition, positive culture and two-tier test, and the positive IgG immunoblot. And these are in this one, last one is in a section called presumptive laboratory evidence. So how would your case be determined to be classified, for example, as confirmed, probable, or suspected? Well, first, they want to know, do you live in a high incidence or a low incidence jurisdiction, now meaning state? And do you have lab evidence of infection? And if so, what type of evidence, confirmed or presumptive? Well, the bottom line is, based on all of this, if you live in in a low evidence state, you need to provide a higher level of evidence for your case to be considered a CDC reported case. And these high incidence jurisdictions / states as of 2021 are 16, which are listed here. Now, what has happened is this impacts the access to care for patients, and we call it diagnosis by geography. Patients from low incidence states have a lot of difficulty finding doctors locally. Few doctors in their areas diagnose and treat. No Lyme here, doctors will often tell their patients, and they often won't treat their patients. So the delay in diagnosis and treatment can lead to persistent symptoms, meaning chronic Lyme. Patients from low incidence states travel long distances to high incidence states for care. And doctors in high incidence states have heavy patient loads already. They have long waiting lists. They may not be taking on new patients. Many experienced physicians are retiring, and not many pediatricians are treating children. So if patients can find a treating doctor, their travel will be expensive. They may have to fly. Overnight stays, time off work, and bringing family may factor into that. Now, patients' care in high incidence states is also affected by the same thing because their doctors already have heavy patient loads and they're taking in low incidence state patients, and that impacts their practice. So according to the MyLyme Data Patient Registry, 26% of respondents have no access to doctors who treat. So for the Tick-Borne Diseases Working Group report to Congress in 2020, I authored the minority response, Effects of Geographic Restrictions on Lyme Diagnosis. Now, are the Lyme cases in low incidence states being shortchanged? Well, the CDC says Lyme is most prevalent in the 16 states, and those are what they call the high incidence or high jurisdiction now. Yet Harvard Medical School study from 2010 through 16 showed that Quest positive lab test rates indicate dramatic geographic expansion in positive rate for Lyme across the US, with a high positivity rates in many states previously considered low incidence. So this expansion was supported by Fair Health Database, is over 23 billion privately billed healthcare insurance claims, which showed significant discrepancies in 3 low incidence states between reported Lyme case numbers and healthcare claims numbers. All 3 states rank in the top 5 for Lyme-related insurance claims. North Carolina, 32 cases reported, 88 plus thousand health claims. California, 90 reported, 46,000 plus health claims. Texas, 31 reported, 31,129 health claims. So what about the years 2016 to 2021? Fair Health study showed private insurance claim lines with Lyme diagnosis in 2016 and 2021 showed that in rural areas they were up 60%, and in urban areas they were up 19%. According to the Daily Mail, which used the Fair Health data and Johns Hopkins data, they listed 11 states with the largest increase in Lyme disease claims during that time period. And 8 of those 11 were from low incidence states. So what about our progress on Lyme disease? Well, interestingly enough, the COVID-19 pandemic has caused focused attention on long COVID and chronic Lyme symptoms, which can be the same or similar. So researchers, doctors, advocates, patients have been discussing the similarities. Apparently, government will be brainstorming long COVID and, quote, long Lyme early next year. New tests by specialty labs on Lyme and tick-borne diseases, new research on persisters, and established biobank and tissue banks are out there now. The patient registry, MyLyme Data, with the real-world evidence, information from daily life, are great tools for advocates to use, and I use them all the time with legislators. For the CDC 2022 Lyme surveillance case definition permits other methods of testing, which is a step forward. Although the definition is not intended for clinical diagnosis, for sure, that will cross over into that area. Incorporating language into labor HHS appropriations and Department of Defense appropriations, we've been able to get more monies for tick surveillance and control and important language surrounding persisters and persistent Lyme symptoms, and more monies for DoD research grants to go into the burden of disease stressed. More private funding for Lyme and tick-borne disease is very positive. For example, Stephen and Alexandra Cohen Foundation giving to universities and nonprofits and partnering with government. ILADS and its Lyme guidelines have increased recognition and credibility. They were on the National Guidelines Clearinghouse before it had to shut down because the government didn't have any more money for it. And they were then the only Lyme treatment guidelines that met IOM criteria, which is now the National Academy of Medicine. And ILADS presents a conference in the US and Europe every year. Some recommendations in the HHS reports to Congress, the tick-borne working groups, have spurred agencies to improve their response to tick-borne diseases. The NIH, for example, did not have a Lyme strategy, and that was recommended by the working group. And the NIH put out a notice and solicited public input and created this strategic plan. And lastly, there are things that we can and hopefully should have learned from the HHS Tick-Borne Disease Working Group. The working group focused attention publicly on how government agencies' perceptions of chronic Lyme disease have remained relatively unchanged. So advocate actions need to continue outside the confinements of the working group. The Lyme community needs to continue to fund and encourage research, including new treatment modalities, support legislative language that ensures monies for tick-borne disease will go where they need to go to help patients, encourage Congress to require agencies to have a process, including the public, for Lyme language posted on their websites, since the science is unsettled and the agencies seldom present both viewpoints on Lyme. And at this time, I thank everyone. And I just want to say a little quote on progress. Behold the turtle. He makes progress only when he sticks his neck out. And I say this because I think that everyone that has worked to move Lyme disease forward sticks their neck out. And I thank everyone.
Pat, thank you so much. Yeah, so I guess I had some questions for the group. What do you think are the biggest challenges that Lyme patients face these days?
Uneducated physicians.
And in what respect?
Well, for many patients, if they themselves don't understand the lay of the land in Lyme disease and they present to a clinician who clearly hasn't been taught about the full breadth and depth of Lyme disease, they're likely going to run into a wall. So physicians who don't understand tick-borne diseases tend to become obstacles to patients for accessing good care.
And when a patient does hit that obstacle, what do you think is the best strategy for them to overcome it?
Well, as from a clinician viewpoint, I would say to find another physician.
That was my instinct too.
I don't think a patient has much power to educate a physician. I think that their energy is best spent for trying to find someone else.
I think this is a really important topic because what we see happening with patients when they enter the healthcare system seeking care is that they frequently can't find physicians who are educated in treating Lyme disease, particularly chronic Lyme disease. And so they have to find care outside of their usual place of getting care. And that makes it very difficult. They have to find out which doctors treat it, which ones have experience, where are they located, do they need to travel? It's a daunting task for patients who are sick.
It is, Lorraine. And if I can jump back in, and it's impossible to, no matter how many materials a patient hands over to a clinician, they will not carry the same weight if the clinicians get educated somewhere else. But in the moment, you're not going to be able to educate that physician.
Yeah, and I think that the education of the physician is something which we have worked very hard with government entities trying to get that changed, because we would like to see the guidelines for Lyme disease not being restricted to guidelines which don't even allow for patients to have care if they have persistent symptoms. And so there has to be some way to persuade the government. And that's what I see as one of the biggest problems, is persuading the government to change their minds in that particular area. Something has to be done. We can't be restricting our patients from getting treatment because a guideline says that after a short term, they're finished. Even though they may be symptomatic, they can't have any more treatment.
Yeah, I think you've hit on a really important point, Pat. The government has the position of power to influence the type of care that clinicians provide in an extraordinary manner. And if they were able to say, here's what we know, here's what we don't know, and by the way, there are divergent viewpoints, and some people believe this and some people believe that, and you need to, as a patient, seek out the care that's going to align with what you need to make yourself better. But as it is, we've got one set of guidelines that says no care for patients who have chronic Lyme disease, and another set of guidelines that says we're willing to try, let's see what works. That makes a big difference. And then I just want to swing back to the point that you made about low incidence states, because that feeds into it. If you're in a low incidence state like California, and you mentioned this in your presentation, you're going to go to a clinician and they're not even going to have Lyme disease on their diagnostic radar. So when they're evaluating you, you're more likely to be called a psychiatric patient or a chronic fatigue patient, or be misdiagnosed with some other condition that overlaps and has no treatment options other than palliative care.
Getting back to the points both of you raised, there is some good news on the government front. So the working group, the last cycle that I was on, we did have some movement around continuing to notify people on government websites that there is divergent views. So I think that was a recommendation we had coming out of your committee in the 2020 report, and we carried that forward. And so there is some movement there. The other movement is to look at the science, right? To know if what we think we know is actually true versus what is partially known and which is unknown. And so we did, through the working group, have a recommendation for HHS to bring in the National Academy of Medicine to do a review with the stakeholders that we need in place to look at the underlying science, because at this point, we're still arguing over science, and that shouldn't be.
Well, I think.
Yeah, go ahead, Pat.
Sorry, I was going to say, I certainly agree with that, Betty. And I think that also brings up the fact that the NIH seems to be very reluctant to bring forth any more clinical trials. And that has been problematic since the clinical trials that have been done, they were a long time ago in the past. And the conclusions were conclusions that not every researcher thought were valid ones. And so the NIH really needs to come forth. And I know that we pushed for that in when I was on the working group, and I think you pushed for that in this particular working group. But so far, I haven't seen any change that they're going to do that.
Well, I think it's a really important point, Pat. I think they've actually said that they do not intend to conduct any more retreatment trials. And, you know, Dr. Fallon, who has made the point that what's going on really is that people are looking at conclusions of studies rather than findings. And the findings are pretty clear that treatment can be beneficial in some patients, but the NIH has not been interpreting it that way, and that has harmed patients.
Which gets back to being able to have neutral arbitrators look at the evidence. So people who know how to analyze trials, but necessarily don't have a big stake in tick-borne disease itself, and let them say, these are the findings, because what has often happened is there's a narrative that we want to reduce the use of antibiotics. So that's a goal of NIH because of concerns over antibiotic resistance. And to further that goal, they sometimes twist findings into conclusions that match the narrative, but really don't match the evidence of the trial. So I think that that's one of the problems we face. And interestingly enough, many people on the working group did bring up the fact that, we're going to hold Lyme patients hostage to the concern of antibiotic resistance, yet we still have a tremendous amount of antibiotics used in the agricultural business. So it's kind of like you are throwing the Lyme patients under a bus that's going to keep rolling, because we have to look at other uses of antibiotics that are more extreme than what we ever see in Lyme disease. I think,
Yeah,
Lorraine,
and
you had some information.
I'm sorry. And building on the theme of hope, I think it's really important right now that, particularly given the NIH has not been conducting any clinical retreatment trials for over 25 years, patients can't really sit on their hands. So one of the things that has happened over the past 10 years has been the use of innovative research techniques. And My Lyme data is an example of that. We allow patients to pool their data, and then we're able to analyze that data to see what's working for different patients. And that's how we're going to make progress, is going to be by having different groups. And I know the Cohen Foundation has funded a lot of different activities. This is how we're going to make our path forward. And when you think about what can a patient do, what can an individual patient do? Well, the My Lyme Data Registry, which has been used extensively to influence and shape public policy, as Pat was mentioning earlier, it's easy to enroll in the My Lyme Data Registry. And that data is extremely useful in terms of being able to start charting a path forward. So even at their sickest, this is something that a patient can do that can make a difference in terms of forwarding research in Lyme disease.
And also what you mentioned, and I had mentioned earlier, is that with the Cohen Foundation having funded Clinical Trials Network through Columbia University, and other institutions are participating in that, our patients have an opportunity there to become part of some perhaps trials that will be moving forward from that. And maybe that's a better place for our patients to go, because Betty mentioned the neutral arbitrators, in the government area. So if we have a private area doing this, maybe there's less, need to worry about that concern, and that hopefully the data that we get out of that will help move the field forward.
Yeah, and I think these aren't toggle switches. It's not this or that. It's the efforts that are going on at Columbia, the efforts that are going on at Johns Hopkins, the My Lyme Data Registry, the Lyme Biobank. It's all of these things coming together and building a knowledge base for a disease that really doesn't have a knowledge base at this point.
Well, it doesn't have a knowledge base that's been put out there in its entirety. Let's put it that way.
That's
some
true.
of it has been suppressed, some of the information.
Yeah, I couldn't agree more. I mean, we're very encouraged about the Clinical Trials Network and the work that we hope gets done over the next few years. I did have kind of going back to one thing that Dr. Maloney mentioned around finding a new doctor. Are there any resources that patients can use to help that search for a good doctor?
Well, I mean, we have a physician registry, and I know that the Lyme Disease Association has a physician, resource as well. I think you have to go to the organizations that know who the clinicians are, and then look in their databases to see if you can find a clinician near you. But expertise really matters in the treatment of Lyme disease.
That's great. And I guess just finishing up with one last question. Quickly, what are each of you hopeful for in the future with Lyme disease?
I'm hopeful about all the people who are working together. So I'm hopeful, like Pat's here, Dr. Maloney's here. We've all worked on the tick-borne disease working group. We've all worked together to promote healthcare policy change. We're all working together to push research forward. And that's there's this new momentum and dynamic in the community that I think is just fabulous, with lots of different organizations picking up the oar in the area that they can lend an expertise.
Pat or Betty?
Oh, well, that was so well said that it's kind of hard to follow. I'm hopeful in a smaller way for diagnostics, because I think improved diagnostics will really help clinicians not only take care of patients in the clinic, but it will really open their mind to everything that they've kind of discarded in the past. So if they were told Lyme is more prevalent than you recognize, and they would poo-poo that, with new diagnostics, we'll really be able to identify just how large this patient population is. And new diagnostics will help design clinical trials, because now we can do trials where we really know that we're working with patients who have Lyme disease. I think diagnostics, I'm very hopeful, and I keep hearing from those people that it's almost here, it's almost here.
I guess I have to say that my hope is for that we have to absolutely be everybody in this country, everybody, quite frankly, in the world, needs to be committed to the plight of the patient. And by being committed to the plight of the patient, everyone needs to recognize that we've got to stop with this logjam that with government and conventional medicine not wanting to do something for patients who continue to remain sick. And we need new diagnostics, obviously, and we need more treatment protocols. And we need the doctors to be allowed to prescribe the things that they feel are necessary when their patients are sick. We've got to stop, degrading them, and we've got to stop bringing them up on charges. And we have to support them. And they, in turn, can support our patients getting better.
Yeah, I agree. If an outcome doesn't benefit the patient, what's the point? Patient outcomes are the single measurement of how effective you've been with whatever you have done. And I think that all of those points that you raised are important, Pat, and also the low incidence states, how difficult it is for patients to get diagnosed in those states. And then also we have the supply demand crisis going on, where there are not enough treating clinicians, and there's a lot of patient demand, and the patient demand is really growing because case numbers are growing. And right now there are things that suppress physicians from going into the field or staying in the field. And those include the threat of legal liability or other regulatory action. In the study that Dr. Maloney and I published recently, we showed 39% of practitioners who treat chronic Lyme disease had been subjected to some regulatory action. That's extremely high. That's extremely high. And we need to, that needs to be eliminated. And the primary place where that could be eliminated would be by the government turning down the volume on the debate and allowing for there to be more clinical innovation.
I think that's very well said, and I think patients would certainly appreciate that world. So I just want to thank the three of you so much for taking the time today, and look forward to talking to you more in the future.